Thank you, sir. And at the outset, I thank the organizers of Slendo to invite me here. Well, Dr. Atul just spoke about challenges, and I mean, challenges are many, many to enumerate. And one such challenge, I call it a challenge, yes, I'll be talking about herbal therapies in diabetes. I believe all of us are clinicians here. I think all of us see patients, and patients are taking herbal therapies. Sometimes they do admit, and sometimes they don't. So how do we, what is the evidence, and what is a pragmatic approach that we should follow? That is what I will trying to talk in this session. So these are called CAM, complementary and alternative medical approaches. What are the CAM approaches? Actually, there's a wide range. Complementary refers to therapies that are used in conjunction with conventional therapy, like herbal therapies. I mean, patient is taking drugs from modern medicine, and he's also taking drugs from the conventional side. Alternative medicines, I mean, these are those medical systems that have evolved rather before the modern medical system. Example being Ayurveda. So, I mean, so commonly practiced in India and the Asian subcontinent. And integrative medicine is a rather broader view. I mean, integrating many medical systems together, and that is what probably most patients are doing these days. The types of CAM therapies can be biologically based, it can be mind-body medicine. The biological based are the ones that actually I'll be talking about today, herbal drugs. Then we have manipulation and body-based practices. Then energy medicine and whole medicine systems like homeopathy, naturopathy, and Ayurveda. So this is in a nutshell the categories of CAM therapies that patients do resort to. Now, India actually is called the botanical garden of the world. Why so? Because there are lots and lots of herbs. WHO lists more than 21,000 of them, and more than 2,500 actually are from India, and 150 of them are used on a commercially fairly large scale, not just India, in China, even in the Western world. How popular are these? Well, all of us know these are popular, but actually how popular are these? This is data from US actually, and this health survey actually says that a third of individuals actually resort to these therapies, and entailing huge cost not covered by insurance. So this is from one's pocket pay. Still, people do resort to this. This is data from Israel. Once again, every fourth individual is resorting to alternative therapies. Why these are so popular? Despite we say that we don't have enough evidence, well, we know that diabetes is a chronic disease. There is no cure. And what everyone wants is actually a cure of a disease. Maybe just like a pneumonia, we take antibiotics and the pneumonia goes off. But that is not true for diabetes. So in search of that, people resort to it. There is dissatisfaction to the modern methods of medication. We just talked about resistance to take insulin. I mean, very commonly we all of us see patients. There is concern about side effects of drugs. I mean, not that herbal drugs don't have side effect, but it's a general perception that they don't. Then, as I said, there is desire to have a grip on the course of disease. There's desire to modify that disease and, if possible, to cure oneself of diabetes and, for that matter, any chronic disease. And most importantly, CAM therapies are, I mean, inherent to our beliefs, particularly in South Asia. I mean, we grow up learning of Ayurveda, and they are concomitantly based into our religious systems as well. So very easy to resort to them. But what does evidence say? Do we have evidence, to recommend alternative therapies? Well, ADA does not. ADA says that there is insufficient evidence, and it does not recommend prescribing alternative therapies. This is Cochrane database review, systematic review of Chinese herbal drugs of more than 16 trials involving more than 1,300 patients. What this found out was that there is some improvement in impaired fasting glucose and impaired glucose tolerance with use of these drugs across trials. However, they fall short of recommending their use. Why? because the heterogeneity of trials, one, trials are not properly randomized, lack of details of what other drugs the patient was on. We never know patient may be on the modern medical drug as well. So we don't know which drug actually brings about the benefit. Unclear methods of randomization, as I said, and poor reporting of side effects. So all these led to this, these authors finally not recommending the use. Then this is another Cochrane review of Ayurvedic drugs from India. Yes, they also said that there is some significant glucose lowering effect, but once again, because of heterogeneity of trials and not improper reporting, once again falling short of recommending the use. So what are the issues with the alternative therapies? Particularly herbal medicines and supplements, actually what we get these days are a complex mixture of those drugs. Usually we don't get individual drugs, just like the way we get in modern medicine. So much so that we don't even know about the individual drug mechanism of actions, not very clearly. The side effect profile of these combinations would be even more difficult to assess. So that is one issue. Secondly, there are pharmacokinetic and pharmacodynamic interactions. As far as the pharmacokinetic interactions are concerned, these drugs can be enzyme inducer or inhibitor. And so there are, interactions with the modern medicine. For example, if someone is on sulfonylurea and also takes a drug that inhibits its metabolism, hypoglycemia can be a clinical outcome. Similarly, pharmacodynamic interactions, synergistic and antagonistic effects can be there. Examples being ginseng, garlic, and bitter melon. They have additive effects to the drugs that predispose to hypoglycemia. So that is just one example. Then yes, contaminants. Heavy metals have been shown to contaminate these drugs, not just in India, but in US as well. So this is a reality, particularly lead. And chronic intake can lead to intoxication. Then even this is actually a report of 2 cases. Glibenclamide has been found to be as a contaminant in these drugs. So, the entire belief, comes to standstill with this evidence. There is such evidence. So, the question now is, what do we do? We cannot stop our patients from taking it. Let's accept that. It's just not possible. If we are judgmental, the patient will not tell us that he or she is on these drugs, but he will still continue to consume. He may or may not consume the drugs that we prescribe, but he or we will continue to take these alternative therapies. So even the ADA says that we should, the word is should, we should inquire about these alternative drugs that the patient is on in a non-judgmental way, because otherwise patient won't tell us. Yes, there are specific situations that we should strongly recommend against use of these alternative therapies. Then if you ask me, the diabetes management, actually we can discuss in 3 broad categories: initiation, titration, and intensification. So what do we do with these alternative therapies in each of these quarters? Well, I do not initiate, simplistically because the world guidelines do not recommend. But most of our patients are already on these drugs. And what do we do when we need to titrate and intensify this regimen? Should we or should we not continue? So that is what I'm going to discuss about in this, the rest of the discussion. History taking, actually, as we all know, that 1 in 3 or 4 individuals is on these drugs, and he or she may conceal from the care provider. So we should, take history by not being critical of patient's beliefs, and only then the patient can tell us. And we should, this is very important, we should discuss the available evidence of efficacy and safety and the drawbacks thereof. We should inform the patient. Well, the first actually row here, no herbal drug actually falls in this category, in which there is high evidence of efficacy and high evidence of safety as well. This is the category that we usually recommend. Then most of the drugs fall in these 2 categories. Either the evidence of efficacy or the evidence of safety is inconclusive. So the idea here is to inform the patient that this is what the evidence we have, and let the patient be his or her own judge. Yes, there are situations where we must avoid recommending. I mean, we should not recommend anyway, but these are the situations where we definitely have to stress upon their possible adverse effects. One, because of the inherent nature of these drugs, we don't know exactly, and secondly, because of the contaminants. Children, type 1 diabetics, pregnancy, definitely we must avoid. Lactation, any surgical or medical illness, any stress, severe symptomatic hypoglycemia. I mean, these are pretty much the indications where we give insulin in diabetes. So we can remember it that way. So in these patients, we must avoid. Now, there's a long list of actually Indian herbs, and I cannot, enumerate all of them. The more common one actually are the combinations that are available. And in India, we have from the Department of Ayush recently, BGR 34 and IME 9, these are the two combinations that are available, and they are available on the net as well. People do consume them in vast numbers. So they are a combination of multiple, not just herbal drugs, but other nutrition supplements as well. These actually, I won't be enumerating all of them. There are a lot of other combinations as well, Dibacon, Diasulin. Now, diabetes is actually diabetes. And any way of therapy, any drug that helps us with glycemia management actually has to work in any of the ways in which modern medicine actually works. It can either be managing insulin resistance, it can be, insulin secretagogue effect, enhancing insulin secretion from pancreas, or it can be, working on the incretin system. Whatever mechanism of action we know for all these drugs, herbal drugs, they can also be pragmatically classified. There are multiple mechanism of actions, but based upon the main mechanism of action, we can still classify them into type 1, type 2. This is one such approach. Type 1, those drugs that work on insulin resistance. Type 2, those who improve beta cell function and hence are insulinotropic. And the other type 3 is the ones that act on the incretin system, especially the GLP-1 receptors. So this is the simplistic classification. If we take a closer look, the ones that act on the incretin system are the ones that actually belong to the spices category or the bitter drug category. The most common ones are ginger, we can see here. Then we have turmeric, we have chili pepper, we have bitter melon, the Karela as we call it in India. So these are the drugs that are anorexigenic. GLP-1 is anorexigenic. These are the drugs that bring about weight loss. Then another category is one that act on beta cells and bring about insulin secretion, much like sulfonylureas. And the other category, licorice, and we have cinnamon, fenugreek, all these improve insulin resistance, the basic mechanism behind type 2 diabetes. So this is one pragmatic classification. It is not flawless. It is just a pragmatic approach of, based on what knowledge we have of the main mechanism of action of these drugs. So based on this, just the way we do a metabolic triage of our patients for type 2 diabetes, for modern medical drugs, we can somehow follow the same. And mind it, I'm not recommending the use of these drugs. I'm just saying that in anyhow patients are taking these drugs. So we, can help them decide which drug to take and which drug to avoid. That is all that message that I want to convey. So based on this metabolic triage, we can classify patients into two broad categories, or rather three broad categories. Those who are predominantly catabolic, example being first presentation of diabetes, sometimes we see patient comes and tells us that, Dr. Saab, I have lost maybe 6 or 10 kgs of weight in the last 6 months. So that is catabolic, the variety. Absolute insulinopenia is there here. It's not just insulin resistance. The other one is maladaptive anabolism, whereby there is florid insulin resistance, hyperinsulinemia, overweight, obesity. And in the middle is eubolism, somewhere in the middle of the two. So based on this, we know that these patients who are catabolic, they actually, in the modern medicine, we prescribe insulin for them. They need to gain weight. They need to have anabolism. And the other one, we give drugs that improve insulin resistance, metformin number 1. We also give, GLP-1 receptor analogs for this category of drugs. So based on this, we can, advise, or rather, help decide which drugs are to be given for which category of patients. For someone who is catabolic, we avoid giving, prescribing ginger, or we can avoid telling the patient to take bitter melon, or chili pepper, all these, the variety that act on GLP-1 receptor type. So those can be better avoided here. Malabsorptive anabolic, here the ones that actually help improve insulin resistance can be, I won't say advised, but we can tell that if you are bound to take any herbal drug, these are the ones that you better take. So this is just a pragmatic way of approach. Just to summarize, we know that not just India, not just the Asian subcontinent, even the West population does take herbal drugs, alternative therapies. There is a lack of definitive evidence based on latest Cochrane reviews of both efficacy and safety. Mechanism of action is clear for some, but not clear for all. We as clinicians cannot ignore that CAM usage is there. We cannot ignore that CAM can bring about side effects. There can be interactions. So until further evidence is available, we can use one pragmatic way that I just discussed of usage. This can be probably the best way out as of now, until more guidelines and more evidence accumulates. So thank you. That's all from my side.